Here we are with chapter 28, and in this chapter we're going to talk about toxicology. This is a pretty in-depth chapter, and it's going to contain a whole lot of information. It would be really easy to get bogged down in it if you don't brush up on a few things to start off with. If you had a really solid foundation in pharmacology, a lot of this stuff's going to come fairly natural. However, if your foundation wasn't really strong in pharmacology, you might want to go back and review some of those terms and look at some of those key medications, because that is a big focus of what this chapter is going to be about. So let's get started. It's really important to realize that in order to effectively manage a toxicological emergency, the paramedic must be able to accurately identify the toxic substance or substances that are involved. And then you're going to have to formulate a well-developed differential diagnosis, and as well as a treatment plan that's tailored to the expected clinical progression of that condition. To do this, providers must have a strong knowledge in the various toxic substances and medications that we're likely to run into out there in the field. Having a really solid understanding of pharmacokinetics is essential for the appropriate care of these patients, and that's why I mentioned having a good solid pharmacology foundation is going to be really helpful, because those pharmacokinetics really come into play here. So let's just start off with reviewing some common terms, some common toxicological terms. So toxicology is the scientific study of the harmful effects that a chemical, physical, or biological agent has on living organisms or the ecosystem. This field also includes the development of methods for prevention and treatment. Pharmacokinetics refers to the study of how drugs move through the body, including the process of absorption, distribution, metabolism, excretion, and this is commonly known as the ADME. So if you hear it abbreviated, it's oftentimes abbreviated as ADME, absorption, distribution, metabolism, and excretion. A drug is any substance, excluding food and medical devices, that is used to diagnose, treat, mitigate, or prevent a disease, or to alter the body's structure or function. The therapeutic effect of a drug depends on its proper use and the appropriate dosage of that particular drug. A poison is a substance that can damage the body structures or impair their functions through a chemical reaction, and even small amounts may cause severe illness or death. A toxin, on the other hand, is a poisonous substance that is naturally produced by living organisms such as bacteria, plants, or animals. Licit refers to something that is legally permitted and or authorized by law. Illicit, on the other hand, describes something that is illegal and not permitted by law. And then we have an overdose, which an overdose occurs when a person ingests or is administered a substance in a quantity greater than that which is recommended, which may or may not lead to toxic and or harmful effects. Not every overdose is going to lead to a serious problem. It just means that they've taken more than they've taken or been given more than what is recommended is technically considered an overdose. Bioavailability is the proportion of a drug's administered dose that successfully reaches the systemic circulation in its active form. So how available is that drug once it's gotten into the system? And of course, half-life refers to the amount of time it takes for the concentration of a substance in the blood plasma to decrease by half in an average individual. So how long does it take? Well, how long is that half-life? Excretion is a process through which a drug or its metabolites are removed from the body. And of course, an antidote refers to a substance that counteracts or reverses the harmful effects of a poison. So Toxicological emergencies can be classified as either intentional or unintentional exposures. Intentional exposures may have included suicidal ideation or attempts, criminal activities involving substances like Rohypnol or GHB, and incidents related to chemical warfare. Unintentional exposures often result from neglect, medication administration or storage errors, idiosyncratic drug reactions, or confusion involving medication regimens. Evaluating a patient's medical history is important to consider when there's any recent changes in medications or dose. The potential for polypharmacy involving multiple prescriptions is real, and the use of over-the-counter medications, home remedies, or herbal supplements can all have an impact on whenever a new medication is added. Children are particularly vulnerable to toxicologic emergencies, making this population a significant area of concern for clinicians. Workplace environments may also involve specific risks that contribute to a toxicological incident and require careful consideration during the assessment and treatment process. Poison control centers are a vital resource for the management of toxicologic emergencies. Healthcare providers can contact them at 1-800-222-1222 to obtain assistance with identifying substances, assessing their toxicity, and receiving recommendations for appropriate interventions to reduce the effects of poisoning. Digital tools are also available to aid in the management of toxicologic cases. There are several mobile applications that can be used to identify pharmaceuticals quickly, and there's more and more coming out. There's the Web Poison Control Platform. This is operated by the National Capital Poison Center. These tools offer mobile applications as well, and they're free to the public to use as well as healthcare providers. Data collection by the Poison Control Centers contributes to a regional public health surveillance. This information helps track endemiological trends. They identify emerging public health risks, and they guide the development of evidence-based treatment protocols. So toxic exposures through ingestion can result in either immediate or delayed effects depending on the substance involved. Caustic substances often cause immediate tissue injury upon contact. When evaluating a case of ingestion, it's important to consider the specific substances involved and determine whether the exposure was intentional or accidental. Common sources of toxic ingestion include household medications and domestic chemical products. In certain cases, individuals may intentionally ingest substances to smuggle or conceal the illicit drugs. Body packers typically hide drug packets inside of their body cavities, while stuffers rapidly ingest drugs in an attempt to avoid arrest or detection. A high incidence of suspicion should be manifested for individuals who are traveling or evading law enforcement and who present with symptoms of an overdose. Indications of possible ingestion include discoloration of the fingers, lips, or tongue, sudden gastrointestinal symptoms such as nausea, vomiting, or diarrhea, and the presence of prescription or over-the-counter medication containers, especially if labels show expired dates or irregular pill counts. Inhalation exposure occurs when a toxic substance is presented in the air and is breathed into the lungs, whether the exposure is intentional or accidental. Toxic inhalants can include gases, vapors, aerosols, or airborne particles that pose a risk when inhaled. Emergency responders must always remain vigilant for environmental hazards that may be present in an inhaled that may present an inhalation risk. When hazardous airborne substances are present, specialized respiratory protection such as self-contained breathing apparatus may be necessary to ensure a safe environment. Always maintain a high index of suspicion for inhalation poisoning, even when it's not specifically indicated by dispatch information. Be alert for chemical suicide incidents in which individuals intentionally mix household chemicals in enclosed spaces to create toxic gases. These gases are often colorless, odorless, and extremely hazardous to first responders. Look for evidence of suicidal intent or environmental clues that may suggest this scenario. Inhaled toxins can rapidly cross the alveolar capillary membrane and enter the systemic circulation, leading to a quick onset of symptoms. Early recognition and timely intervention are essential for effective treatment of inhalation poisonings. The safety of responders must always take top priority. Use appropriate respiratory protective equipment and relocate the patient to a safe area before conducting an assessment or initiating treatment. Clinical symptoms can vary depending on the substance that is inhaled, but you want to gather as much information as possible to help identify what substances are involved. In residential settings, ask the patient or bystanders if they can provide any clues. And in industrial settings, consult safety data sheets, shipping documentation, placards, or use tools like Whisper for substance identification. Notify poison control and medical command without delay to facilitate proper treatment and guidance. If hypoxia is suspected, administer high flow oxygen and support ventilations as necessary. Establish IV access to facilitate fluid administration or medication delivery. And apply an EKG to continuously evaluate any cardiac effects of that toxin. Use pulse oximetry and capnography to assess and monitor the patient's oxygen and ventilatory status as well. Injection poisoning commonly occurs as the result of envenomation, which happens when toxins are delivered through a bite or a sting of an animal or insect. These types of envenomation can vary depending on the geographical region. The southwestern United States, common envenomations include snake bites and scorpion stings. In coastal areas, people are more likely to encounter envenomations from jellyfish, Portuguese man-of-war, sea urchins, and anemones. Nationwide, wasp, yellow jacket, and hornet stings are common sources of envenomation. Injection toxins can lead to neurotoxic effects and provide local and systemic inflammatory responses, which may result in swelling, redness, or even systemic symptoms depending on the substance. Physical exam findings can help guide the diagnosis, especially when assessing localized reactions at the site of the injection. However, symptoms can vary widely depending on the nature of the toxin and the site of injection. EMS intervention may be required for complications arising from intravenous drug use. Common substances associated with such complications include things like heroin, cocaine, amphetamines, and those combinations of like heroin and cocaine, what's referred to as a speedball. Absorbent exposures typically lead to a slower onset of symptoms, which can make it challenging to immediately assess the severity of the exposure. Pesticides are a common source of poisonings, and they are often absorbed through the skin and can cause a range of symptoms depending on the chemical involved. Symptoms may include nausea, vomiting, diarrhea, sweating, muscle twitching, and seizures. Of course, scene safety should always be prioritized. When dealing with absorptive toxins, ensure that the environment is safe for both responders and the patients. Be aware of any ongoing sources of exposure, especially if that's like pesticides that have been applied to an area or chemical spills. Decontamination is often necessary with these patients and may require the involvement of a hazmat team to safely manage the toxic substance and ensure a proper removal from the patient's skin and clothing. Decontamination efforts should be initialized early to prevent further absorption or contamination of responders. If aerolized particles are suspected, ensure proper respiratory protection is utilized, such as N95 or P100 masks, to prevent inhalation of toxic particles. So, a toxidrome is a set of symptoms that are linked to a specific group of poisons or drugs. Identifying these symptoms can help diagnose and manage these poisoning cases when they come up. There are 6 main toxidromes to recognize. So these toxidromes are what these drugs essentially have in common. For instance, opioids, we would expect to see a certain set of signs and symptoms with opioids, whereas a sympathomimetic drug would have a different set of toxidromes, as would cholinergics or sedative hypnotic drugs and anticholinergics and serotonin syndrome type of drugs. This is really going to encompass a lot of what we're going to talk about moving forward in this chapter. So we're going to talk about these specific categories, and then we'll talk about their specific toxidromes. So understanding those toxidromes is going to be essential in helping to kind of backtrack what it is that they may have been exposed to. And you can oftentimes make a working diagnosis based on the patient's history, physical exam, and vital signs by knowing these toxidromes that are involved. So here is a table that shows the 6 major toxidromes, as well as some examples of the drugs or toxins that may be associated with each one, and the side effects that are commonly seen with those. This is a good one to look at. It's in chapter 28. And is actually the first table in that chapter. A wide variety of substances are being used today, and this list continues to grow and grow. There's an ongoing debate about whether there's medical use versus benefits, and the side effects can be mitigated or minimized. The definition and perception of substance misuse often differs from culture to culture as well, so there may be some differences when it comes to misuse. Drug misuse refers to using drugs in a way that causes harm, whether that's physical, psychological, economic, legal, or social. This harm is caused to the user or to others affected by the user's behavior. And then habituation is when a person becomes psychologically or physically dependent upon a particular drug. Physical dependence is when the body adjusts to a drug, leading to tolerance and withdrawal symptoms when that drug is stopped. Psychological dependence is an emotional craving for a drug. It's driven by the need to feel good and to maintain that well-being. Of course, tolerance occurs when the body requires higher doses of a drug to achieve the same effect that was once felt with a smaller dose. As a person uses a particular drug, oftentimes this tolerance is developed and it grows. And when they stop using that drug, we see something called withdrawal syndrome, which refers to a predictable set of symptoms that occurs when a drug is suddenly stopped or reduced, often affecting the central nervous system. Drug addiction is a chronic brain disorder marked by compulsive drug seeking and use. Despite the harmful effects on physical, psychological, social, and legal well-being, they continue to utilize and seek this drug. An antagonist is a molecule that binds to a receptor without activating it. The result is it blocks that receptor and prevents the response that the receptor would normally have. It blocks it, and this agonist kind of holds that spot. The antagonist holds the spot so the agonist can't trigger the receptor site reaction. Potentiation occurs when one drug enhances the effects of another drug, even if the second drug has little or no effect on its own. Synergism, on the other hand, happens when two or more substances interact, producing effect greater than the sum of their individual effects. The principles of patient assessment are the same for all of these, but those with an altered mental status, it's crucial to continuously monitor airway and breathing. For the unresponsive patient, we're going to make sure that we get a full set of vital signs, perform that rapid full body scan to spot any immediate threats that may be present, and then gather as much history as possible from bystanders and family. For the responsive patients, we're going to use the OPQRST mnemonic to assess their symptoms, get a good set of vital signs, and use the sample history mnemonic to get a complete history. Conduct a rapid full body scan with these patients as well for those immediate threats, but then we're going to follow this up with a detailed secondary and physical exam. Always reassess for potential hazards throughout the situation. These types of situations that involve, drugs and medications and abuse and that kind of thing are fraught with other safety issues. So it's really, really important to keep an eye out for safety hazards as they may crop up. Some telltale clues to look for are medication containers, household chemicals, written notes, those kinds of things. Overdose patients may pose a safety risk, so you want to be sure that you approach those patients cautiously. And of course, call for law enforcement or crisis intervention if necessary, depending on the circumstances that you find yourself in. This figure shows some commonly misused substances. We have methamphetamine, cocaine, bath salts, synthetic cannabinoids, ecstasy, and marijuana. All of those are kind of represented here, but realize there's always new things coming out, new ways that they're going to package and hide these. So you have to kind of be on the lookout for this. Some of these substances are coming in highly concentrated forms that can be readily absorbed through the skin. So it's really important that anytime you see any of these things or any of this paraphernalia or anything like that, not to touch it with bare skin. Always make sure that you're providing a barrier between your skin and any of these substances, because they may be absorbed. We're going to talk about marijuana here in a little bit, and the concentrations of marijuana that we see today are much higher than once was, and they keep increasing and increasing. So we have to be careful with that. So our primary survey, of course, we're going to quickly assess the patient's condition and try to form a general impression of what's going on. Look for those immediate life threats that need that urgent attention, and then determine the nature of the illness, as well as looking for any kind of mechanism of injury if there's the possibility of injury. The severity of the condition, we're going to utilize that severity of the condition to prioritize and guide our treatment process as we move forward. Of course, we want to make sure that we use solid airway management to help gather more information and stabilize the patient. A thorough history using OPQRST and sample is essential whenever that is possible. Be sure to ask what substance was involved, because that's going to provide a lot of direction, and it may be more than one substance involved. If you wind up transporting them to the ER, make sure that you bring the medication containers with any remaining contents. If there was, it's an industrial thing and there's safety data sheets that were involved, make sure you bring them along. A photocopy of drug labels is helpful if the container can't be transported. And a sample of the ingested plant or material or that kind of thing, if it is safe to collect, is really helpful too. Obviously, you don't want to bring highly toxic and unsafe things to the emergency department. So photos and that kind of stuff would be beneficial as well. Knowing when the exposure happened is really, really crucial too. So because as acute onset often signals a more severe case. So if it's a shorter onset and it's more acute, this could mean a larger exposure to whatever that particular substance is. Determine as best you can how much of that substance was taken, injected, absorbed, or inhaled, as the dose often correlates with the severity of the effects. Check medication labels to estimate the missing amount. You can count pills and do those kinds of things and backtrack from when it was filled. Sometimes that's helpful. It's not always helpful though. Identify any other substances that may be involved, as this is going to help the ER staff kind of decide on the necessary diagnostic tests that they may need to run that may be really critical to get those tests done in a short amount of time, and delays might be problematic. Ask if the patient is vomited or aspirated, and of course note the time of exposure and if possible how much they vomited. Look for pill fragments or identifiable components in their vomit if you can, if the vomit is still available. If it's in a clear bag, consider transporting it to the emergency department so they might be able to do a closer analysis of what it contains. Ask about the reason for the exposure, but be careful and avoid making assumptions about what happened. So get the story from them. If the presentation is unusually medical, so the secondary assessment, or if the presentation is unusually medical, so the secondary assessment should be thorough and adapted to the patient's condition. So these situations are medical emergencies, so we'll tailor that secondary assessment to the needs and the conditions and the presentation of the patient. Of course, we're going to focus on the mental alertness and of nausea and vomiting risks because we want to protect that airway. For trauma patients, we're going to form assessment based on the mechanism of injury, and it is very possible to have a medical emergency rolled into a trauma, especially when we're talking about the use of the intentional or unintentional use of drugs and medications. Regularly check the patient's condition and adjust your priorities as needed. Assess how well whatever interventions that you've used are working, and this reassessment usually happens during transport to the receiving facility, and depending on how long the transport is will kind of determine how many times you're going to keep going back and reassessing and reevaluating. Of course, the more serious the patient is and the faster they're deteriorating, the more often you're going to reassess those important areas like airway and LOC. When providing emergency medical care to toxicological emergencies, always ensure that the scene is safe. Remember, these scenes can actually go downhill pretty quickly, even though when you get there they seem relatively safe and everything's kind of okay. Realize that these scenes can deteriorate, so make sure safety is always a concern, and you don't want to spend a ton of time on scene with these unless you just absolutely know that it's say a medication error. Establish and maintain a clear airway, and make sure that the patient's respiratory function is adequate and remains adequate. Maintain the stability of the patient's circulation, and administer supplemental oxygen to keep the oxygen saturation at or above 94%. You should establish an IV or an IO just in case medication or fluids are going to be needed. Consider administering a specific antidote or mitigating the medication if it's clinically indicated and available for the patient's particular condition or drug that's affecting them. Be prepared to manage potential complications such as shock, coma, seizures, and dysrhythmias during treatment, and this may be very medication dependent, and it may depend on a few other factors that come into play depending on what it is they've been exposed to. Ensure that the patient is promptly transported to an appropriate medical facility for further evaluation and long-term care. So let's get into some specific toxins, drugs, whatever you want to call them, medications. Of course, alcohol is not really a medication. At one time it was. So alcohol is a central nervous system depressant that is quickly absorbed through the gastrointestinal tract and can act as a diuretic. It's primarily metabolized in the liver, and chronic alcohol use will lead to liver damage. Withdrawal symptoms can range from mild, such as tremors, to severe, like in cases of severe delirium. So some key signs of acute intoxication are altered mental status, slurred speech, unsteady gait, and emotional swings in combativeness. This doesn't necessarily mean that somebody has an addiction to alcohol. It just means they're intoxicated. Management of that patient's going to include prioritizing supportive care, focusing on airway, breathing, and circulation. And of course, we're going to continuously monitor those vital signs to ensure and maintain patient safety. Now, if a patient is experiencing withdrawal symptoms, we want to consider administering benzodiazepine to manage the agitation and prevent seizures. We rehydrate the patient with IV fluids and provide nutritional support, specifically thiamine and maybe D50 to prevent Wernicke's encephalopathy and some of those more severe cases of withdrawal. People may rely on alcohol to manage emotional stability or social interactions. Alcohol depresses the frontal lobe, which impairs judgment and reduces inhibitions. Regular heavy alcohol consumption can lead to physical dependence. And then a sudden cessation triggers withdrawal symptoms, which can range from mild, such as restlessness, anxiety, insomnia, agitation, and maybe some slight tremors, to severe, which can show things like hypertension, tachycardia, vomiting, hallucinations, and delirium tremens. At the advanced dependent stage, individuals may resort to drinking non-alcoholic beverages such as mouthwash and hand sanitizer when they get extremely desperate. Chronic use will increase vulnerability to further illness and injury. Alcohol causes neurotransmitter imbalances, brain damage, and impaired cognitive and motor function. It leads to mucosal irritation and increases the risk of cancers, including oral and esophageal cancers. Chronic use impairs the liver detoxification process, and this contributes to portal hypertension and esophageal varices. But remember, it's important to realize that not all portal hypertensions and esophageal varices is the result of alcoholism or chronic alcohol use. There are some other causes of that, so be careful just making that broad assumption. This table actually shows the medical conditions which people with alcohol abuse disorder are particularly susceptible to. And if we look at this, we can see all of these things. Some of these, it's pretty clear that it has to do with the inhibitions or impairment of the prefrontal cortex. And this is going to be especially true in young adults or early adulthood, late adolescence, where that portion of the brain's not completely formed already. Adding alcohol to the mix further causes, those deciding issues not to turn out too well. Alcohol, as mentioned before, is a central nervous system depressant that suppresses excitatory neurotransmitters. The effects of alcohol depend on the amount consumed and the individual's body size. Blood alcohol content is used to assess the level of intoxication. Respiratory depression and the risk of aspiration are the major concerns in cases of severe alcohol intoxication. When managing an unconscious alcohol-related patient, we need to always make sure that the airway is clear. We should always have that suction equipment ready because of the high risk of vomiting and aspiration. Administer supplemental oxygen as needed, and of course we're going to assist with ventilations as indicated. It's always a good idea to go ahead and get good vascular IV access on these patients as well. Monitor the EKG for potential arrhythmias, though it's not real common to have arrhythmias with these patients. These are not one of the arrhythmia common medications. Check blood glucose levels to rule out hypoglycemia, which can oftentimes mimic or worsen the symptoms. Administer IV thiamine following in accordance with your protocols. And of course, transport the patient promptly to an appropriate facility for further care. Alcohol withdrawal seizures typically occur within 12 to 48 hours after the last drink. Following the same general approach as acute alcohol intoxication by prioritizing airway breathing and patient safety, consult medical control for guidance on administering benzodiazepines or lorazepam or those kinds of things in the management or prevention of seizures. Delirium tremens typically begins 48 to 72 hours after the last drink, but the onset could be delayed. DTs are a true medical emergency that requires prompt recognition and intervention. Common signs and symptoms are going to be confusion, tremors, restlessness, fever, tachycardia, hypotension, and the hypotension is often due to dehydration. Cognitive effects can include hallucinations, hyperresponsiveness to stimuli, and a marked cognitive decline. Treatment priorities for DT should prioritize the safety of both the patient and the provider while still supporting care to the cardiovascular functions. It's helpful as much as possible to keep the patient calm and reduce external stimuli. And of course, avoid standing in dark shadowed areas in order to prevent the patient from misrepresenting you as a hallucination. If the patient is agitated or combative, of course, you're going to have to follow local protocols for law enforcement assistance in the use of benzodiazepines. Provide supplemental oxygen as needed, get an IV as needed, treat hypotension with normal saline infusion, and try to maintain a calm, ongoing dialogue to help orient and reassure the patient to what's going on. So stimulants is the next category. Stimulants will present differently than alcohol. And of course, stimulants can be taken orally, inhaled, or injected. And believe me, they use all those routes. These typically increase the catecholamine release, stimulating the central nervous system, so they heighten the central nervous system. The effects are going to include things like increased alertness and euphoria, to agitation, hyperthermia, tachycardia, hypertension, and even seizures. Common clinical presentations are going to include agitation, anxiety, maybe delirium, dilated pupils, restlessness, fidgeting, profuse sweating may be present as well, and the patient often appears thin due to the high energy expenditure and the long-term use. Potential signs of use include track marks, burns, or other injuries. Behavioral clues will include sleep deprivation, anxiety, paranoia. Of course, always with these patients, we should maintain a high degree of situational awareness of what's going on. Be aware of your surroundings and anybody else in the room. It's not unusual for EMS to get called for one person that is experiencing a delirium or something like that, only for other patients to begin experiencing, or other people to begin experiencing the same thing and see you as a danger or a threat. So make sure you maintain that high degree of situational awareness. The first of the stimulants that we're going to talk about is cocaine. Cocaine has long been considered kind of the rich man's stimulant because it is more expensive than some of the others that are out there. It is derived from the coca plant that is found in South America and is processed into cocaine hydrochloride to increase its potency. Ironically enough, this was one of the first ingredients in Coca-Cola, and that's where Coca-Cola got its name. Of course, don't go out stocking up on Coca-Cola. It no longer contains cocaine or any elements of the coca plant. It was actually initially used for various medical treatments, and that's where Coca-Cola was developed. It was actually a over-the-counter or a medical treatment that was brought forth, with that particular drug in it. Occasional use of less pure forms carries a lower risk of dependence, but chronic use can lead to significant physical, psychological, and social problems. Cocaine can actually act as an anesthetic and a powerful CNS stimulant. Cocaine effects on the neurotransmitter dopamine and norepinephrine. On dopamine, it causes intense euphoria and heightened alertness. And on the norepinephrine side, it stimulates the sympathetic nervous system that leads to tachycardia, hypertension, hyperthermia, and vasoconstriction. Cocaine hydrochloride is rapidly absorbed via snorting, injection, oral ingestion, and topical application. A smokable form was created by combining cocaine and baking soda and water, and then heating it into bricks or blocks, and then they would break it off and smoke it. And the smokable form is commonly known as crack. When snorted, the onset's within 1 to 5 minutes. When smoked, it's almost immediate, and it's within 8 to 10 seconds. The smoked version, the crack version of cocaine, is extremely habit forming because of the fast onset. Frequent use, especially in higher purity, increases the risk of developing tolerance and dependence. The crash phase, or the, hang on, let me get this back up here. Good grief, it just jumped. Sorry. The crash phase or post-use symptoms include depression, irritability, and exhaustion. And then there's something called cocaine washout syndrome. It's a hypoactive state that results in depleted neurotransmitters, which can be subtle and often difficult to assess, but basically they've burned up everything that they have. There's no neurotransmitters left. And then there's some coping strategies to avoid that crash that oftentimes users will do. They'll either redose with more cocaine, or they'll take some sedatives like benzodiazepines to kind of bring themselves down, and then they sleep through the crash. Individuals with heroin dependence may use cocaine to actually relieve withdrawal from the heroin. So some of those symptoms, they may use cocaine to bypass those. So signs and symptoms of cocaine use can include chest pain, which is often associated with a myocardial ischemia or infarction, and it very well may be a cardiac event that's going on. Shortness of breath may be caused by pulmonary edema or myocardial infarction or direct toxic effects to the lungs. There may be excessive sweating, which is often seen in most stimulant toxicities. And of course, agitation, paranoia, delirium, hallucinations are all possible with cocaine. Cardiac effects can include ventricular dysrhythmias, which are very common and can lead to life-threatening arrhythmias like ventricular fibrillation. Cocaine-induced vasoconstriction increases the risk of a heart attack, and sudden cardiac arrest can occur due to these severe arrhythmias, especially in patients with pre-existing heart disease. It's important to watch for widened QRS complexes that are often seen in stimulant toxicity and that can lead to dangerous arrhythmias. Prolonged A prolonged QT interval is another common EKG abnormality with cocaine toxicity, which can predispose the patient to arrhythmias. Chronic or prolonged cocaine use can cause cardiac remodeling and left ventricular hypertrophy, increasing the risk of arrhythmia and heart failure. This is often due to the vasoconstriction that raises the blood pressure and puts the heart under a greater workload. This vasoconstriction can also lead to heart attacks in the heart because of the increased workload that the heart is placed under, and if there's any pre-existing blockage or issues with the cardiac or the heart vessels as well. Cocaine can also cause strokes, seizures, or other neurological deficits, as well as cocaine-induced rhabdomyolysis that can lead to acute renal failure. So it's important that we're vigilant for signs like muscle pain, dark urine, and elevated creatinine levels. Those things are going to be an indication that there's significant kidney damage going on. Another common stimulant is amphetamines. This is the more common one that we see in the poorer parts of the country. A few common types that we'll see are the traditional methamphetamine, which their street names are crank or ice. This is a highly addictive drug that causes intense euphoria, and it's often smoked for rapid onset. MDA or Atom is a psychoactive drug with both stimulating and hallucinogenic effects. And MDMA, also known as ecstasy, it's known for the euphoria and sensory enhancement, often mixed with other substances for a greater effect. These actually, believe it or not, methamphetamines do have some clinical applications. They're used, for example, in decongestants and diet pills, in some over-the-counter medications, and they're even used to treat narcolepsy, ADD, and ADHD by prescription medications. However, these do have an increasing amount of misuse. Prescriptions such as Adderall and Ritalin are often misused in schools for enhanced focused and even recreational use. Amphetamines are highly addictive and contain many harmful additives. There is a rising trend of misuse, particularly among students, for those taking Adderall or Ritalin, to help increase their studying, improve test scores, and those kinds of things. And this misuse by these students is among students, some of the higher performing students, because especially those that see the grades as really hyper competitive, and wanting to, be the valedictorian or whatever of their class. Methamphetamines are generally low cost, long acting, and highly addictive. They're easily produced and locally available because they're made by a variety of ingredients that can be bought over the counter. Federal regulations recently aimed to control its production by limiting access to some of those easily found things. But meth labs, remember, are very hazardous, and they're going to require specialized hazardous material protocols because of all of these chemicals that are involved. Symptoms are similar to cocaine abuse, but meth's effects last much longer. Key signs are going to be euphoria, agitation, hyperthermia, tachycardia, and paranoia. Follow the same protocols as we would for a cocaine overdose, managing ABCs, dealing with agitation, and supporting vital signs. Be aware, though, with these patients, the paranoia may escalate, so law enforcement may be necessary to ensure the safety of the first responders and to help manage that patient in a more effective way, because remember, law enforcement does have the ability to restrain people in a way that we might not be able to in the pre-hospital setting. Law enforcement can actually place somebody under a medical hold where we don't have the ability to do that. Synthetic cathinones or bath salts are derived from the cat plant and engineered for higher potency. So they're synthetic, but they're a derivative of a plant, sold as plant food, cleaners, and labeled as not for human consumption. They're not to be confused with things like Epsom salts and that kind of stuff, which Epsom salts are usually found in a white or brown crystal form under names. The bath salts are usually found in a white or a brown crystal form that looks similar to Epsom salts, but they're going to be under names like Flacca, Cloud9, White Lightning, that kind of stuff. These are easily accessible at convenience stores and gas stations, although state and federal governments have tried really hard to crack down on these. And typically they do that by making certain ingredients illegal. However, they just try to find a different chemical ingredient to substitute for that and put it back out there. They can be ingested, snorted, smoked, or injected. And of course, snorting and injected are linked to much higher mortality rates with these particular drugs. Effects include paranoia, hallucinations, and bizarre behaviors. Excited delirium and increased strength are not uncommon with these. Some physical signs that we're going to see is tachycardia, sweating, nausea, and hyperthermia. Bath salts can include some life-threatening presentations, and so they might show up with dysrhythmias, vascular events, severe hypertension or hyperthermia, seizures, or agitation. We should focus on supportive care and maintaining oxygenation as best we can, and continuously monitor EKGs, continuously monitor the EKG for signs of dysrhythmias, and more than likely, if you can, assess or place an IV and administer fluids or medications as needed. Key interventions should include maintaining a solid airway, administering supplemental oxygen to keep the O2 sats above 94, securing good vascular access for future medication or fluid needs, and of course monitoring the patient's EKG, pulse ox, and capnography to have a much better clinical picture of how they're managing. Additional management steps for stimulant misuse might include administering benzodiazepines. Of course, this is going to be protocol dependent, but this would help with controlling anxiety, seizures, psychosis, and some of those things. Managing hypotension with fluid infusions of normal saline. Of course, you should follow your local protocols or reach out to medical control anytime sedation is necessary. You should be able to just kind of flip over to your seizure protocol if your patient has a seizure and manage that, following local protocols. And of course, transport that patient to the appropriate medical facility for further care and treatment. Fluid resuscitation may be necessary if the patient's showing signs of hypoperfusion. Of course, watch for those cardiac dysrhythmias. These may be significant and they may require immediate treatment. Chest pains in these patients should be treated as if they're having acute coronary syndrome, but we can also consider some other symptoms such as respiratory distress and atypical acute coronary syndrome presentations, because these do have a high likelihood of having cardiac involvement, and if we don't treat the cardiac involvement, it could have long-term consequences for that patient. If it's not contraindicated, consider sublingual nitro to try to help alleviate that chest pain, and continue to manage those other cardiac symptoms that are related to ischemia. And then some signs of stimulant overdose and excited delirium may include things like bizarre behavior that can often be aggressive and very irrational. These patients can be found naked, and possibly because of hyperthermia or agitation. These patients will often strip down because they get overheated and hot because of the drugs that they've taken. They may have a history of non-compliance with their psychiatric medications or antipsychotic medications. Chemical restraints and sedation may be necessary to ensure patient and provider safety. Of course, oftentimes when it comes to this, we're going to have to involve law enforcement because they're the ones that can offer us to use physical restraints on somebody. But realize these patients can be extremely strong and they can harm themselves if we just physically restrain them. Oftentimes it's going to be a combination of chemical and physical restraints. Of course, you're going to have to follow local protocols and use the appropriate agents, whether you got antipsychotics, benzodiazepines, or those dissociative agents that you might have available. Aggressive cooling for those hypothermic and severe agitated patients may be needed as well. So when that's the case, apply external cooling packs to the groin, axillary, forearm areas. Aggressive fluid therapy is often necessary as well, and this will do to maintain a good urine output and manage dehydration. If the patient experiences seizures, follow that protocol, which may include benzodiazepines. Lastly, neuromuscular blockade may be required to manage severe agitation and prevent hyperthermia, acidosis, and kidney failure. However, online medical control is typically required before initiating any kind of neuromuscular blockade on these patients. All right, so that's the end of part 1. We will be back with part 2 of chapter 28, and we'll continue talking about some toxicological agents.